we meeting at this way?
You have I thought I did, but I could be wrong. We can get started. You ready? You ready? Good morning. Welcome to Know and Go. My name is Jim Mugen. I'm the Chief Operating Officer of St. Agnes Hospital. Today I'm filling in for Holly, and really thanks, we really appreciate you coming today. If this is your first Know and Go session, welcome and thanks for coming. If this is not your first session, thanks for the continued support. Now before we get started too far, we do want to start with a reflection. May is National Mental Health Awareness Month. We ask that you join us in reducing the stigma that surrounds mental illness, substance abuse, and those suffering from addiction. Mental illness does not discriminate. It occurs in every county, every state, and across the nation. It affects all demographics, race, and economic status. Let us share the support for mental health awareness and show those that are suffering they are not alone. To make a difference in someone's life, you do not have to be brilliant, rich, beautiful, or perfect. You just have to care. So a couple housekeeping items. Just a reminder, we are connected by video conferencing with Ripon Medical Center and Waupun Memorial Hospital. Are you guys both there today? Can they talk back? Can you guys hear us all right? Okay. Some things on your table. We're going to do something a little different today. We're going to have a panel discussion. So our next, that's for today. For our next month on Friday, June 12th, we'll have our new chiropractors. Dr. Andrew Judkins and Dr. Brian Hensland will be joining us. I'll be talking about chiropractic services. The yellow feedback cards, please keep that coming. The feedback allows us to continuously improve and make these sessions more and more meaningful. So please take the time to fill those out. There's also a green slip that you'll have in front of you. And if you are interested in receiving credit or a chance to win Veggie Bucks, please fill that out. And we will pick that up towards the end of the presentation. As I mentioned, our format's a little different today. We have a panel. Each panel member is going to talk about 5 minutes, and this will be a challenge for this group. And you can see there's a lot of talented people up here that are very, very educated and very experienced at mental health and addiction issues. So if you have questions, we're going to ask that you save them at the end. And if we run out of time, put the question on that white slip of paper in front of you, and then we'll put it on the what do you call it?
Vital signs.
The blog, and then we'll put your question there, and we'll provide an answer that you're going to review at a later time. With that, I'm going to introduce Dr. Jim Salasek, the Director of Behavioral Health Services.
Thank you. Thank you, and thank you for coming. Although I'm not sure what he meant by that comment, because we're usually accused of being better listeners than talkers. So I want to talk a little bit, give you a brief overview of what we're about today. We're going to talk to you a little bit about behavioral health. There are 6 divisions in behavioral health, and we have representatives from each of those areas. They're going to give a brief overview of where we're at, what we do, and who we are. We're going to talk a little bit about what mental health is and what mental disorders are. Mental health is one of the 8 dimensions of overall wellness. It is coping effectively with life and creating satisfying relationships. Mental disorders are differences in thinking, your mood, or your behavior that interfere with your ability to meet your daily responsibilities. So that's the baseline, that's the reference point we want you to think about. Mental disorders come about for many different reasons. Genetics plays a role in many, just as other health conditions, but there are nutritional factors, there are social factors such as unemployment, poverty. They impact a person's ability to cope, and they often create the condition that results in a mental disorder. Many mental disorders are situational, and most people recover from. This is a little bit of statistics. There is approximately between 1 in 4 and 1 in 5 individual adults in the United States on an annual basis that will experience a mental disorder. So if we had you count 1 through 2, 3, 4, 1 in 4 of that group is likely to experience a mental disorder in this year alone. It's a significant number of people. It doesn't always impact your ability to function. About 80% of the people who have a mental disorder will experience some disruption in their ability to function and meet their daily responsibilities. So why is this important? This is important because your mental health will significantly impact the other dimensions of wellness. If you attend to your mental health, you'll attend better to all the other areas of functioning. This is just a little bit of data on depression alone. Almost 19 million Americans will suffer some type of depressive disorder this year. This year. 80% of them will be impacted. 15 million of the almost 19 million, 15 million of them will suffer a lesser condition of depression, and about 5 million will be more seriously impacted. Now the problem is, a significant number of people don't seek help. And that is partially the result of stigma and a misunderstanding of mental disorders. This is some of the cost. Depression alone in the United States causes over 200 million lost workdays. 200 million lost workdays. It will account for between $17 billion and $40 billion in lost productivity. And we also know, besides the lost workdays, there's a term called presentism. People coming to work impaired. Impaired because of drinking, impaired because of a mental disorder, and that also accounts for some of the lost productivity. So what can we do? Well, of course, the first thing you can do is you can seek help. You can seek help early as soon as you recognize that there's a problem. And in doing so, it'll enhance your ability to have meaningful relationships and be a productive individual both in your family and at work. So here are just some of the factors that will contribute to improving your overall health. Better communication skills, seeking out support, seeking out quality health care. That's both mental health care and physical health care. They go together. Having good peer groups and social connectedness. That's the basis for what we're going to be presenting to you today. And now I'm going to turn it over to Jamie Carey, who's our Director of Inpatient Behavioral Health Services.
Good morning. My name is Jamie, and I'm going to be sharing some information with you today about the inpatient unit. So the inpatient behavioral health unit is an acute psychiatric unit designed to promote a therapeutic environment, to promote healing for individuals who may suffer from mental health disorders, emotional, behavioral, or substance abuse concerns in a manner that's consistent with Agnesian HealthCare's overall mission and values. We have the ability to care for 16 patients at a time. We have semi-private rooms as well as private rooms. There's a large group room on the unit. We have a dining area, a recreational area, multiple consultation rooms where the doctors and staff meet with the patients on a daily basis. It is a locked unit for added safety. So again, we want to promote a therapeutic environment that is really conducive to promoting and maintaining wellness, health, preventing illness. We are able to care for patients who are 18 years of age and older, and typically a patient may be admitted for crisis observation, short-term care, acute psychiatric care, or substance abuse concerns. So you may say, what is crisis observation or what is acute psychiatric care? I'll give you an example of maybe a person who may be suffering from bipolar disorder. They're at home, they're starting to have more manic symptoms. They're really struggling in their job, in their home life. They come to the unit. We work with them to help adjust their medications maybe, and just work on some healthy coping for them. So we have a plethora of professionals that work on our unit, and they include registered nurses, licensed nurses, addiction counselors, psychiatrists, spiritual care providers, dietitians, pharmacists, and we are your treatment team. And we put the patient at the center of that treatment team to make sure that we're providing person-centered care and we're working on that patient's specific goals. So we work very hard with you and really individualize the treatment. So we make sure we're addressing that specific concern that the patient is presenting, and we work with them on a daily basis to make sure they're safe and we get them home back to their baseline so that they're able to function. Our professionals not only meet one-to-one with the patient, but throughout the day it is organized in a way as such. Starting at 9 a.m. we have group therapy sessions, and they run on the hour every hour until about 3 p.m. And then we also have an evening groups called Reflections. So the professionals that I mentioned in the previous slide, they may hold group therapy sessions on medication education, disease process education, healthy coping skills, stress reduction, relapse prevention. Again, they're focused on the patient population that we have at the time. So access, how do you become a patient on the behavioral health unit? It really can be done in a number of ways. Oftentimes it's a referral from a physician. Maybe a primary care physician will be working with the psychiatrist. Also, counselors say, I'm working with this patient, they're having difficulty, I think they might need some inpatient care. There are a number of brochures on the table today, and in the inpatient behavioral health brochure there is a phone number listed. If you're unsure on whether or not a loved one needs inpatient care, please call the numbers that are listed on that brochure, and one of our staff members would be happy to help you navigate the system, because we really want to make sure that you are getting the right care at the right time and in the right place. On that note, we do have a partial hospitalization program, which is set up very similar to the inpatient. The patient has access to the same professional team. They have daily access to a physician, one-on-one with the nurse. The difference here is that after the 3 p.m. class during the day, they are able to go home in the evening. Then they come back the following morning, check in with the nurse, how did things go last night, and that program runs 7 days a week. So physician referral is required for that program. The inpatient is obviously 24 hours a day, 7 days a week. So we do have different levels of care, and that way talking to a staff member may be a really good idea, so we can help guide you through that system. So that again was a very brief overview, but if there are any questions at the end, I'd be happy to answer them. And next we have Amy Johanna. She is the clinical supervisor of addiction services.
Good morning. As many of us are painfully aware, addiction is a chronic and progressive, sometimes fatal illness. I think oftentimes we fall short of understanding that recovery is possible. You'll notice that we have the 8 dimensions of wellness up here. And in 2011, the treatment team decided that we would incorporate the 8 dimensions of wellness, and we refer to it as wellbriety, wellness beyond sobriety. And a really good example of how we incorporated it, and I look at Chaplain Dawn as I share this, I remember going into the first group and sharing that we were going to be incorporating spiritual care into our program. And many of the guys in group were like, well, that's not going to happen. And they're like, well, we're just going to leave. And now those individuals are the biggest supporters of Dawn. Like, where's Dawn? When is she coming? If you have the opportunity to go to the chaplain, I'm sure many of you have seen the cross that's on the wall. Several of our recovering addicts and alcoholics created that with the work that they've done with Chaplain Dawn. So that's just one example of how we've incorporated the 8 dimensions. We provide services, addiction services, 363 days a year here at Agnesian. And so as a result of that, all of our staff, addiction staff, is cross-trained. And all of the staff is licensed and capable of providing initial assessments, one-on-one therapy, group therapy, aftercare planning, discharge planning. On the inpatient, we offer 3 different levels of care. Our most intensive level of care is inpatient. And on the inpatient unit, in order to access or have access with an addiction counselor, a physician referral or consult is required. Not only do we provide initial assessments on our inpatient behavioral health unit, but we also provide initial assessments throughout the entire hospital. Along with the initial assessment, we provide one-on-one, we provide group therapy, discharge planning. Primary counselor that works that position is Ann Fridner. Then the step down that's less restrictive than inpatient is our day treatment program. And we have 2 counselors that share that position, Gail Bigsby and Stephanie Kickert. In order to access day treatment, you do need a physician order. Primarily, we receive patients in this level of care when they step down from the inpatient unit, or if we're working with individuals on an outpatient basis and they're not being successful in their recovery, we can refer up to day treatment. The program, kind of what Jamie had said, the difference between partial hospitalization and our day treatment program is their primary diagnosis in day treatment is chemical dependency. And that program runs 7 days a week from 8 until 4 p.m., and they attend groups throughout the day. Our least restrictive level of care that we provide is outpatient. We have 3 providers in outpatient, Mary Arndt, Lori Oleg, and myself. Here we provide, if you want to access the information, all you have to do or make a referral is to call outpatient behavioral health. You can call us directly, we can facilitate that. We receive providers or referrals from individuals from different locations, police detentions, court referrals, and we provide individual, group, family sessions. One of the things that we also provide is referred to as an intensive outpatient program. And this program is a flexible program. It runs 5 days a week, but a patient can decide to come either all 5 days, they can decide to come 2 days, whatever works in their schedule. And it's a group therapy. We also provide a relapse prevention once a week on Monday evenings, and this program is specifically for individuals who have had prior treatment and just need some ongoing support. One of my favorite programs that we developed, and this started in 2011, was our family education program. And what we saw in need is oftentimes individuals have family members that are actively using, and they don't have access to receive services. And so we decided what we would do is develop a program that's 4 weeks in session. It's cash, so it's $40 for the entire 4 weeks. And the focus of that program is how you can survive if someone you care about is active in addiction. So first we talk about what addiction is, and then how do you survive that and maintain your own mental health. We also have 1 outpatient addiction counselor down in Beaver Dam at Psychiatric Associates. And Lori Ross provides the same groups and individual counseling as we do here in our outpatient program. In order to access the services, you can just call the Beaver Dam office and they will schedule an appointment with Lori. Lori does individual, family. She also does groups. One of Lori's primary referral sources is Dodge County and individuals who have been arrested for operating under the influence of alcohol. So she provides 2 specific groups during the week, 1 in the morning and 1 in the evening, as well as she provides a relapse prevention group. And her groups are, in our outpatient group, they're flexible and they're open-ended. Lori her groups are close-ended, so they go for 12 weeks and then they go to a next level of care. And the next up is Dr. Dahl, supervisor at Dahl & Associates.
Thank you. Good morning, everyone. There we are, Kathy. So, Kathy is our receptionist. That would be the first person you would talk to at our clinic. Kathy's also joined by Paige and Megan and Karen for a little while longer, she's expecting. And we have really this kind of setting that's quite remarkable. Agnesian has been wonderful in supporting our rejoining in 2010, And it is really that. Kathy's openness, comfort, she's like talking to mom, you know, and people call in when they're looking for services, and it's not the best time. They're under distress, they're not sure what they're going to be facing. We have an intake form, we have to ask some pretty detailed questions, but in order to connect them to the best possible care we can, Kathy and our support staff are really that first contact. And oftentimes when people come in, they've had a session with a therapist, hopefully it went well and they feel pretty comfortable, usually it does. They are going back out and thanking Kathy, or thanking Megan, or thanking Paige, because they were really vulnerable and we got them to come and have some help. And if we can't, and sometimes there's access issues, waiting lists, or insurance issues, we really try to do the best we can to connect them with services if we can't provide that services. And then we'll ask them to call us back if they can't or navigate the system. And so it's that, you know, part of what care we provide I wanted to share with us, our overall group. And then Sarah Kaiser and Lisa Hall administratively have done a remarkable job along with all of Agnesian. I'll talk about our autism program in a few minutes, but they've been able to hire staff, be able to coordinate care from, we started with 72 families and now we're at 150 affected by autism. And Agnesian has been amazing at changing systems and figuring out how to work through a myriad of problems, but all with success. And so we have a nice location. I just thought that was a nice morning picture. It's kind of where I get to go goof off. I work with kids, and so of course it's therapeutic to go for a walk, and very, very therapeutic to skip stones, especially if you don't know how to skip stones. But walking around the pond, there's some research about trauma and using your body to process trauma, to keep your body engaged. And also there's just something, especially with teenagers, about not sitting across from this getting older guy. You know, we can walk and talk, you know, and we can do eye contact intermittently. And so all of our clinicians, like across all of our system, are very talented, have different areas of expertise. I put up their pictures just so you could see their friendly folk. I know that we weren't able to do that for all of our services just because there's so many of us, but just to give you an idea, the general approach we have is called cognitive behavioral, using some changing in your thinking and specific behavioral interventions. But we also have some expertise in particular areas. For example, there's a process called EMDR, eye movement desensitization retraining, and both Miranda and Dr. Rogers-Dahl use that technique to help work through traumatic memories. Trauma is something that affects many, many of us. 2/3 of us have at least one trauma in our life, and of those, 84% of us have more than one. And so being able to come in and share that trauma obviously is a very risky thing, but to know that there are these processes that we can work through things and doesn't have to be re-traumatizing is a lot of hope, I think. Anne Brunette does a great job with marital therapy, couples. The statistics are about 7 years too late. So a lot of folks come in for marital therapy after they've already kind of been thinking and fantasizing about not being in the marriage anymore. And so when I talk with my kiddos, I talk to the parents and say, look, the best thing you can do for your kids is to stay married. And so if there are priorities in your life, and they certainly are willing to bring the child in, you gotta take care of yourselves. And that marriage is really, really important. And Sarah is just a child whisperer. She does just amazing things with kiddos. So she runs our social skills groups in the summer. She is actually out in the schools. We have a contract with the school district. It's a great partnership where she does a lot of social emotional consulting for 4Ks. Because if we can help children at this very young age learn to self-regulate and manage emotions, we can really make a big difference in their lives. And I don't know about many of us probably weren't taught that, oh, you're upset, you might want to take a deep breath or calm down. Usually it was just shut up, knock it off. And so to really be socially emotionally present and in that relationship can be a very significant gain for people. Assessment clinic, right now we're actively recruiting a replacement for the psychologist, but we really have this wonderful partnership with Dr. Treffer, who's an international expert and savant And really quick, I'll give you an example of one of the areas that he's interested in. It's called hyperlexia, very early reading, 2-3 years old. It's kind of reading out of books. And so when you're evaluating, you want to make sure you know what you're looking for. And so for hyperlexia, some of the kids have autism, and it's sort of this splinter skill of their autism. Some kids are just really bright and early readers, and we're going to be fine. And then some of the kids sort of look a little bit like they have autism, and they also are early readers. And so trying to figure that out is really important for families. The diagnosis of autism can be overwhelming. We do want to correctly identify and get early intervention as soon as possible. But sometimes the kids end up doing okay anyway. And so that difference, that hyperlexia without necessarily the outcome of autism is really important. So we're doing some research trying to figure that out. We have 2 wonderful partners in speech, language, and OT, Renee Allen and Jan Martin. And one of the big parts of autism is sensory issues. And so we really want to kind of look at that whole person. Just imagine what it would be like that, every little clip sound just drives you crazy. It sounds like a, blasting band. It's hard to be in that body sometimes. And so a multidisciplinary evaluation is really important. Megan Ron is on leave with her child, but she's coming back shortly. And one of the things that she does is follow up with families. We want to make sure people don't get lost. It's a very confusing world, especially with these diagnoses and labels and what to do next. And so we really want to make sure that we follow up, and we do that on a regular basis. And then autism. The Beyond Boundaries program is just a lot of amazing things happening. We would like to do a lot more. We'd like to have more parent groups. We'd like to do other things. It's just been 1 year. As I mentioned before, the administration has been exceptionally supportive. All of the departments, HR, IT, everywhere you go within our Agnesian organization, there's a lot to be proud of. And so now we're serving 150 children across 18 counties. And just a year ago, we were serving 73 kids in 13 counties. And this is where you get into the home and you really do the intensive intervention for children on the spectrum. And then we also have other kind of support, mentoring, daily living skills. We're doing a lot more with older individuals, and we would like to do more in terms of supporting the aging generation and helping with that transition to adulthood. And then there's that contact number for Sarah Kaiser, who I mentioned before. And another little program we're trying to get going in, through our volunteer center is having high school students volunteer to help us. And so they'll have that experience and then eventually be able to become part of our treatment team as lines. But it also helps our children doing social skills have access to what we would call neurotypically developing individuals. So with that, I will turn it over to Jamie. Jamie's a clinical psychologist at our Psych Associates down in Beaver Dam.
All right. First, I want to tell you guys just a little bit about Psychiatric Associates. We're on the frontier down south. People sometimes don't even know we exist, but we do. And we treat a lot of different things: depression, anxiety, mood disorders, ADHD. We also do a lot of evaluations, like DVI evaluations, driver safety programs, psychological evaluations. We treat people as young as 3 all the way through geriatrics. We're a full-functioning outpatient clinic. I wanted to today give you a little, I thought I'd give you guys kind of an example of something that we do, so that it kind of makes it a little more real for what the clinic actually does. And I chose to talk a little bit about positive psychology. And positive psychology is the study of what makes us happy, what makes us content, what makes us resilient. How do we snap back from things when life throws us a curveball? And it's not just simply thinking happy thoughts. All right. A lot of my clients, by the time they get to me, have tried that. They've read books that tell them just turn it around and think happy things. And it doesn't really work that simply. Although we do work on optimism, but it's a little bit different than that. So what I do is I do an assessment for their strengths. I want to find out what my particular client does well, and I take that and I try to figure out an intervention based upon that. One of the things that there are a lot of different interventions within positive psychology. The one I'm going to talk about today is gratitude. Now, I know I'm kind of preaching to the choir here because we work in healthcare and we also work for a ministry. So most of us in here know the positive effects of gratitude. You know, we know that there's research on it, and it's the media's really taken off on it. So we know this firsthand. So what I'm going to talk about is 2 interventions that I do with clients that try to cultivate this. And the cool thing about this is it works for people that aren't dealing with depression as well. So, you know, just kind of a tip there. One of the things that I do is something called a gratitude visit. And here what I do with my client is I ask him or her to close their eyes and picture somebody that really did something wonderful for them. Somebody that did something beyond what was, you know, something great that they really remember. But also somebody that they haven't properly thanked for that, okay? And then what I have them do is, and it also has to be somebody that's living and they have access to. Then what I do is I have them go home that night and write a 300-word testimonial. What the person did, how it made you feel, and why it was so important to you, okay? Then they have a week to schedule an appointment with that person, not tell them why they're going to talk to them. And then within that week, after that week, they got to show up. They got to go to that person and literally sit down with them and read the letter. Okay? As you might imagine, it's an incredibly powerful experience, and usually people can't stop but cry. So it can really cultivate that feeling of gratitude in the person giving it as well as the person receiving it. And it's a really powerful intervention. In fact, when we look at this in studies, happiness goes up, depression goes down, and that impact lasts for like a month, which is a pretty significant finding for such a simple intervention. Another thing that I do is something called a gratitude journal. And this is where I have clients every week, once a week, sit down and write down 5 things that they're grateful for. It could be something as simple as my car started this morning to something more momentous like my child's first steps, right? And they have to write that down, write a little bit about what it was like for them. This is an incredibly powerful intervention for something so simple. We find that happiness again goes up, depression goes down, and this lasts for a month, and it lasts in follow-up at 3 months, and then again at 6 months. So it's a pretty powerful intervention for something so simple, and I like to use that a lot with people for that reason. This is, to me, I think the real takeaway for positive psychology, and it's the idea of resiliency, snapping back like a rubber band when things don't go well. And this is something that I learned about in my postdoc program with Dr. Barry Nuremberg in Miami, who knew about this research. It was really important to me because I was working with this group that was really difficult, and I wasn't reaching them. I didn't feel like I was getting there. And he taught me a little bit about the research. And there's a very interesting part of research in positive psychology that shows that people, when we study people who have all these background issues that would predict they don't do well, right? Like AODA issues, trauma, abuse, all these things that oftentimes set us up for a difficult adulthood, but thrive. Somehow they thrived, and we compare them to people that didn't. We look at some of the things they experienced. One thing that comes out that's really robust and important, and that is that somewhere along the line, the group that did well had somebody who believed in them. Okay, somebody who really thought they were something and had communicated that to them. And the cool thing about this finding is it didn't have to be a parent. It didn't have to be somebody very close to them. It could be a teacher. It could be a coach. It could be one of us, right? So I think I carry that with me. I learned that at a very good time when I needed to remember this. But I think it's really important for us to remember that it only takes one. So when we interact with clients, I kind of take that with me when I'm with my patients, and that, you know, this could be the person that really kind of takes it with them in the future. So if you're interested in positive psychology, talk to me. We definitely could talk about this all day. Otherwise, that's a website that gives a lot of information about it. And these are 2 books that I recommend that I think are great for lay people. You don't have to be a psychologist or a mental health professional to understand the way they write it. So I think these are really well done. And with that, I'm going to introduce Tiffany Weiss to the Domestic Violence Program.
My legs asleep. My bad.
Second club.
I know, jeez. As Jamie said, my name is Tiffany. I'm the supervisor of domestic violence services here at the hospital. We are before I get started here, we're a subsection of behavioral health. So we're located on the 5th floor in behavioral health in the outpatient services wing, so to speak. And we share a waiting room with ASTOP, Sexual Abuse Center. we are two separate agencies, so that can be confusing at times because we're kind of located in the same area. But we'll talk about a little bit of the differences between the two agencies to make that a little bit clearer for everyone. So first of all, obviously following positive psychology, we're not going to be talking about such a positive topic, but domestic violence is unfortunately something that affects our community and affects many people nationwide. When we talk about domestic violence, we're talking about a pattern of behavior. Sometimes there's a misconception that domestic abuse is a one-time incident. You know, someone commits a crime, someone says something very abusive, it's a one-time incident. But typically this is a pattern of behavior, and that's something to keep in mind. And it's usually abuse by one person against another, and it doesn't necessarily also have to be a romantic partnership. It can be a family member against another. It can be technically, statutorily, it can be someone who lives with someone else. So when we have law enforcement respond to a domestic abuse incident, it really could be family members, it could be a romantic couple, or it could be two people that are living together that don't really have a romantic relationship. So it also kind of covers a lot of different relationships other than romantic ones. What I have here on the right is the power and control wheel, which I'm not going to be able to go over with you all, but it is important because the center of domestic abuse and abusive relationships is the concept of power and control. And with power and control, there's a lot of psychological components where people are, could be using emotional abuse, putting people down, isolating them, minimizing the abuse, using economic abuse, all these different things that aren't necessarily tangible like physical and sexual abuse are. So it's a very important component to keep in mind. So how prevalent is domestic abuse? 1 in 3 women have been the victim of a domestic violence relationship in her lifetime. So 1 out of 3 women in here, if we really look at that, that's a lot of women. And 1 in 14 men have been the victim of a domestic violence relationship in his lifetime. Why is there a difference between men and women? I get that a lot. How come there's more female victims than male victims? First of all, there is an underreporting component. A lot of men don't feel comfortable reporting if they're being abused, but there's also a lot of women, unfortunately, that aren't reporting either. And there's also a lot of dynamics within our culture, within our society, within our historical origins that kind of create an imbalance between men and women in these situations. Statewide, we don't have our 2014 statistics statewide yet, but in 2013 we lost 51 people due to domestic violence, which typically are homicides, but we've also had homicide-suicide cases. And out of those 51 deaths, 8 of them were under the age of 18. So we're losing children, not only adults, in these situations. Locally, we work very closely with our county police department and our city police department, so we have a lot of really good statistics and numbers as to who we serve as referrals from them. They, in Fond du Lac, just in the city of Fond du Lac, they respond to about 3 calls a day to domestic abuse. And those are substantial calls, so those aren't like, I hear something going on, could you come check out the house? These are 3 calls where something significant has happened, whether it's a strangulation case, whether it's someone destroyed property, whether it's someone stalking another person. That's what those substantial calls are. So who are we? What are our services? We have psychotherapy. We have 2 therapists, myself and Teresa Sokup. We also have 2 case managers. One case manager serves a dual role. And one case manager is Lindsay Swope and the other is Amy Bayer. Amy Bayer is also our prevention educator. The prevention educator is a unique position to domestic violence services. It's a very new position. And from the support of Agnesian and from the support of the Exchange Club in Fond du Lac, we were able to fund that position. And Amy specifically goes into the schools within the area and goes into community agencies and talks about how to prevent these situations and teaches children and teaches teenagers what's healthy relationships, what are unhealthy relationships, and teaches them ways to kind of either report that or receive services to alleviate those issues. We also provide medical and legal advocacy. So a lot of our clients, unfortunately, will want to go through the divorce process, will maybe want to file a restraining order against someone, so we will accompany them to court and help them with that process. As far as medical advocacy goes, we, when we're on call and we have crises intervention services, we may be called into the emergency department, or we may be called to really any department in the hospital and provide a consult and kind of get that person in a safe place if they're leaving the hospital, if they're going to be transitioning out of the hospital. Some physicians even order us to come see a patient before they actually leave, so we can make sure that they have a safe place to go and they have a safety plan in place. So the crises intervention component means that basically we're working a lot. We're working all the time. So we are on call a lot of times, and so if someone comes into the emergency department from law enforcement or just on their own, we have someone that can come right away and work with that person after they've been assaulted and went through a significantly traumatic event. And then lastly, we have some group work. And with our group work, the most important group that we do is our offenders program, which is called the Breaking Abusive Patterns program. And this program specifically works with offenders of domestic violence that are referred to us from the court system, sometimes from other providers in the area. Also, some of our judges will court order individuals to complete the program. And with that, it's actually a 26-week program, and it's the only program of our set of services that requires any fees. And the reason why it has fees is because typically with the court system, they'll have court fines. This person committed a crime. It's a sense of holding them accountable in some type of way. But all these other services up here are free. So that's the biggest thing to sell to our patients, to sell to clients, that they can get all of these services for free. They don't have to worry about insurance or anything like that. And so we're quite busy a lot. With that, we also have, this year, we started a bachelor's level intern program, and also our doctoral level interns do serve some time as part of our program as well, so we have additional staff. So who do we serve? It's really important to know who can be referred to us, or who do we typically see. Obviously someone who's been a victim or a perpetrator of domestic violence, whether that's men, women, children, or any individual who has been affected by abuse against their loved one in the past or currently. One of the also common misconceptions is we only serve people who are currently being abused. But if someone has been abused in the past, we're also a resource for them. We typically only see ages 5 or older. Teresa's our child-focused therapist, and the youngest she sees is 5. Community and legal system referrals, a lot of times we work very closely with the DA's office and law enforcement, and that's where some of our referrals also come from, as well as hospital staff here and our behavioral health providers. And one other thing I want to talk about is where we are. In addition to being here in Fond du Lac, we also have an office in Ripon. So not at Ripon Hospital, but at the Ripon Clinic. We actually kind of share a little corner with EAP, and it's really nice because there's a lot of people out in the Ripon area or Green Lake area that we can serve as well that may not have the transportation to get to Fond du Lac. With that, we've also met patients in Waupun. We've also met patients at all of our other affiliated clinics, depending on transportation issues, depending on convenience and safety. So keep that in mind, that if we have a patient or a loved one who may need to be seen, we don't necessarily have to see them here in Fond du Lac. And with that, this is Evelyn Schaefer, Dr. Evelyn Schaefer, and she'll be talking to you about outpatient.
Yes, good morning, everybody. So I am tasked with trying to summarize everything we do up in outpatient behavioral health in 5 to 7 minutes, so hopefully we'll be able to do that. I'm very excited. I've been here with Agnesian for 14 years now. I'm a licensed psychologist, and this has pretty much become my home for work, and I've transplanted my entire family here, and I'm very impressed with the work that we do system-wide, not just in behavioral health, but across all of the entities. So I'm kind of excited to be here this morning. So, that's the wrong way. We do a lot up on the 5th floor. We are on the 5th floor of the D&T Center, so if you take the 5th floor elevators up, you pretty much end up in our waiting room. We have the medication and evaluation management with our psychiatrists. We do individual psychotherapy, group psychotherapy, couple therapy, and we do assessments, both neuropsych assessments. We have a neuropsychologist who does a lot of things for competency evals, dementia evals, and we can also do other assessments as well for psychological purposes, whether that would be diagnostic clarification or helping come up with treatment recommendations for different providers. We have a lot of providers up there. This is the largest department I've ever worked with. And it's wonderful, though, because we're all in one place, so it's a lovely opportunity to work with a lot of different people with a lot of different specialties. So currently we have 4 psychiatrists. We have general adult psychiatrist, a child and adolescent psychiatrist, which we're so excited to have a dedicated child and adolescent psychiatrist, and a geriatrician as well. 4 licensed psychologists who also emphasize in child and adolescent neuropsychology and health psychology. We have 7 master's level therapists who are both licensed professional counselors, licensed marriage and family therapists, and AODA professionals who have a dual AODA and mental health certification. We also work with our 3 clinical substance abuse counselors, which I'm sure Amy told you all about earlier. So we have quite a big group up there. Areas of expertise are pretty much across the board. We're somewhat one-stop shopping upstairs, so we can help you with mood disorders or anxiety, especially with PTSD, hoarding, panic, phobias, kind of across the board for anxiety. We have an incredibly strong treatment team in the area of trauma, and so we work with people who have experienced trauma across the lifespan. Children, historical trauma, we work with veterans, we work with individuals who have been chronically ill, had terrible accidents, reproductive trauma, so people have lost children. We have an incredibly strong team, which is an amazing thing because trauma-focused care is really something that is special in a community. And having groups at all of our locations that focus on trauma is wonderful. We also have practitioners who do EMDR, and I realize we are a very acronym-heavy health field. So EMDR stands for eye movement desensitization reprocessing, which I could talk about for forever, but long story short, it's a very trauma-focused therapy that has wonderful efficacy, but we really are able to help people who become very stuck in their trauma, have a hard time moving on, and with this therapy are able to move forward and live lives that are worth living. We work with a lot of behavioral issues with our children and with our adults. So things like ADHD, attention deficit hyperactivity disorder, oppositional defiant disorder, anger. We work with a lot of people who struggle with self-harm and chronic suicidal thoughts. And we work with relationship issues across the lifespan, whether that would be marital issues, couple issues, family issues, attachment issues with people with foster and adoptive placements. And so we're really working with the entire family across the lifespan. We have even more areas of expertise. Wow. Lots of identity issues. We do have therapists who are specialized in working with the LGBTQ community as well. Pain and health concerns. We have a health psychologist as well as a pain specialist who is part of the pain department, but he lives in our department, so it's wonderful to have him doing neurofeedback as well. Eating disorders, life transitions, and assessments. So as you can see, we're doing a little bit of everything up on the 5th floor. One of our particular strengths, I think, is our groups. We have them running all week long, and I didn't even think about how many people come through our groups, but it's pretty significant. One of the groups we have is a DBT skills group. DBT stands for Dialectical Behavior Therapy, which is a very interestingly named therapy, but really helps working with people who have struggled across their life with managing their emotions, being able to handle life's curveballs and the distress that sometimes come with that, and struggle in relationships. And so it's very much a skills-focused group that is in addition to individual therapy, and we have had wonderful success with that. People who have been in and out of the hospital chronically for most of their life really are able to learn some of the skills that perhaps they didn't get growing up and lead a much more productive and happy life. We have pain management support groups. We have eating disorder support groups. We do groups on mindfulness and anger, stress management. Our interns have developed wonderful programs in parenting and wellness for the entire community. And we give a lot more talks as well as short-term focus groups as well. So if you're looking for something, you can probably call us up there. Near and dear to my heart is our training program. We have been training master's level clinicians for the last 10 years and have wonderful relationships with many of the master's programs in the area. They are with us for 9 to 12 months, and the master's program are supervised individually by our licensed clinicians, and so they really get wonderful training. The fabulous thing about this is we have hired our master's level interns. We know who they are, we know where they got their training, and it's wonderful to have people who are willing to stay here in the community. Newer is our doctoral level internship. This just began this last year. We've been developing it for over 2 years now. In order to be a psychologist, at the end of all of your schooling, you have to do a year-long internship. And it's full-time work. You are basically acting as a psychologist, just without the title. And so they're here for 12 months. They provide the full range of services. They work with outside agencies. We have people placed at Beacon House. We're working within the school system next year. It's just really exciting. They bring wonderful expertise and excitement. And the really exciting thing is that we have people coming from across the country to train here. Our last group of interviewees came from 7 different states, as far away as Hawaii, to interview here. I felt bad for that individual as it was the middle of the winter, and it was probably a rude awakening, but people are really coming to Agnesian for the quality of the care, and hopefully we can get them to stay in the community as well once they're done. In order to get a hold of us, you can call us up at the 4200 number. You'll talk to one of our support staff. We'll do a general intake. They will match you with a provider or match a loved one with a provider on a basis of a couple things. Preference, whether people would want to work with a male or a female, the provider's areas of specialty, insurance needs, and we are working really hard on increasing access. I know that's always one of the questions people have is how long do I have to wait to see someone? We are working with having departmental liaisons going into the different departments so that we can have more of a relationship with that department and have clinicians who are specialized